discuss the updated classification system for describing the severity and complications of acute pancreatitis, which has been out now for a few years, but it's only recently being published in the literature. And it advocates a new simplified terminology, in particular for describing pancreatic collections. And then at the end, I'll briefly mention, talk about principles of drainage or pancreatic collections. So one of the milestones for classification of acute pancreatitis was the Atlanta Symposium in 1992, which was a global consensus statement by international experts from various disciplines involved in acute pancreatitis. And the attempt really was to try and standardize the terminology being used for describing the severity and complications and the collections. And generally it was successful compared to what had been happening before that time. But some of the definitions still remain ambiguous, and there was still widespread use of long-standard terminology. And that's one of the aspects highlighted by the paper in 2006, where 5 abdominal radiologists were asked to look at 70 pancreatic collections and classify them according to the Atlanta guidelines. And there was full agreement in only 4% of cases. And 4 out of 5 radiologists agreed in only 19% of cases. This is one of the examples of a collection in the left flank, 31 days after the onset of pancreatitis. And one radiologist described this as pancreatic necrosis, another one pancreatic abscess, another person described it as pseudocyst, and 2 described it as a mixture of these descriptions. So with the new terminology, which I'll come on to shortly, we would now call this a walled-off necrosis. It's certainly not a pseudocyst, because pseudocyst by definition doesn't contain solid material. And here we've got necrosis of the telepancreas, which means there will be some solid material within it. So another working group got together in 2008, and the aims of this group was to try and improve the description, improve further the description of acute pancreatitis, again to try and standardize the terminology across the different specialties, in particular how we describe the fluid collections and necrosis, and to facilitate better communication between clinicians, and also to encourage more objective reporting of CT scans, and so to improve patient management. And these are some of the terms that have been should really be abandoned now, because they mean different things to different people. Okay, so definition of acute pancreatitis. Acute pancreatitis is an acute inflammatory process of the pancreas which may involve adjacent or remote tissues and organs. And it's due to inappropriate intracellular activation of enzymes leading to autodigestion of the pancreatic parenchyma and also the surrounding tissue, particularly the fat. There's a release of various inflammatory mediators, and the local effect is a varying amount of edema, hemorrhage, and necrosis in the pancreas and in the surrounding fat. There's also a systemic inflammatory response in the early phase and problems with sepsis of infected collections later on. The new classification describes 2 types of pancreatitis: acute pancreatitis, interstitial oedematous, which is due to diffuse edema within the pancreas but no necrosis, and necrotizing pancreatitis, which involves pancreatic and/or peripancreatic necrosis. The incidence on average is about 22 per 100,000 in England, and is said to be increasing. And the main cause is alcohol or gallstones in the majority of patients. In making the diagnosis, there should be at least 2 of the following: suggested abdominal pain, which is usually upper abdominal pain of fairly acute onset, often radiating to the back. The serum amylase or lipase should be raised at least 3 times the normal. There should be characteristic imaging findings, usually on CT, but could be on ultrasound or MR. The revised classification focuses on 2 phases of pancreatitis: an early phase, which is usually within the first week, and late phase, and both have peaks in mortality. And in the early phase, the main problem is organ failure in patients who have severe pancreatitis due to the systemic inflammatory response syndrome. And treatment during this phase is based on the degree of organ failure. The later phase is usually after the first week, the changes of pancreatitis may resolve, it may stabilize or worsen, and this phase can last from weeks to months, and is characterized by the presence of necrosis and pancreatic collections, complicated by infection and organ failure. And treatment of this phase is based on the symptoms of the patient and morphological criteria by CT. In defining the severity of acute pancreatitis, in the first phase, the severity is related to organ failure rather than the changes that we see on CT. So mild pancreatitis is defined as minimal or no organ failure. And severe pancreatitis, organ failure persists for over 48 hours, and you get persistent systemic inflammatory response changes. In the second phase, the severity is related to organ failure and infected collections. Just briefly mention the clinical scoring systems. There's a variety of systems that are out there, and they're used in the early phase to predict the severity of pancreatitis, and they give an indirect estimate of pancreatic damage and give some prediction of likelihood of complications developing. But they're not universally accepted, and they have limited value in predicting necrosis, persistent organ failure, and predicting death. There's a CT scoring system, initially described by Balthazar in 1994, and this is a more direct evaluation of pancreatic injury. It looks at the degree of inflammation, necrosis, and collections, and gives them a score. The category of pancreatitis is dependent on the score, and that gives you a guide to the prognosis. So a CTSI score greater than 5 is associated with increased morbidity and mortality. There are limitations. There's no definition, there's no involvement of organ failure as a criteria here, vascular complications, and there's also problems with inter-observer agreement when giving a CT severity score. There's a modified CT scoring system that was proposed in 2004, and that includes scores for fluid effusions, ascites, arterial bleeding, pseudoaneurysm, and also GI involvement. And this gives a stronger correlation between outcome and severity than the original description. But with the scoring system, you should remember that there's no direct correlation between clinical severity and morphological change in the pancreas in the early phase, and patients may die early on before necrosis has occurred. Conversely, some patients can tolerate quite extensive necrosis in the later phase without significant organ dysfunction. So the role of CT, acute pancreatitis, aid in diagnosis. It may show the cause of the pancreatitis, the gallstones, or chronic pancreatitis. It helps in assessing the extent and severity of the inflammation and necrosis. It picks up complications and also guides intervention. The CT technique, ideally, we should give oral water as a negative intraluminal contrast medium. IV contrast, usually about 100 ml, given at between 3 and 5 ml per second. Thin collimation, reconstruction interval, anywhere between 1.5 and 3, up to 3 millimeter reconstruction. And the first phase of imaging should be the pancreatic phase, where there's peak pancreatic enhancement, and that's shortly after the arterial phase, at about 30-40 seconds. And then a later venous phase, which shows the portovenous vessels more clearly, and also the liver enhancement at 60 to 70 seconds. Just examples of a normal pancreas. You can see in the early phase, the enhancing head of pancreas very clearly, the SMA, and then later on the SMV is portal vein is shown more clearly. When should we perform CT in acute pancreatitis? If there's diagnostic uncertainty, then it's obviously reasonable to do a CT in patients with acute abdomen. If the diagnosis is already made, then CT should really be ideally delayed for 3 or 4 days when the necrosis has become established, because early CT can underestimate the extent of necrosis. And then follow-up imaging should be based on the clinical need. There is a risk of high radiation dose in young patients with severe pancreatitis who can end up having very frequent CTs. And so for the follow-up, ideally you should perform a single-phase venous phase CT, or if the patient can tolerate an MR, an MR could also be used to follow up collections post-pancreatitis. Is CT always necessary? If there's very mild pancreatitis and rapid improvement clinically, then it's not necessary to perform CT. And there's a proviso in patients greater than 40 years of age. Sometimes pancreatic cancer can present with acute inflammation, and if there's no other cause apparent. What's the pathophysiology correlate of the CT findings? The inflammation of the gland is related to the enzymes auto-digesting the parenchyma and the inflammatory mediators resulting in the edema. The necrosis is related to direct cell injury and death by the enzymes, and also vascular disruption by the inflammation. And that begins very early on after the attack of pancreatitis. And fluid collections are related to rupture of small branches of the pancreatic duct, releasing pancreatic juice, and also reactive fluid secondary to the parenchymal and peripancreatic necrosis and inflammation. The key questions on CT is the degree of pancreatic enhancement. Is there non-enhancement indicating necrosis? Is there fat necrosis, which is also important? The pancreas may enhance normally, but there may be necrotic change in the surrounding fat. And in terms of looking at the collections, we need to see whether there's any solid necrotic tissue in the collection or is it simply a fluid collection. And then are there any features of infection? We should also look at the extrapancreatic findings, the gallbladder, bile duct, the vessels around the pancreas, and also the gut. This is an example of interstitial oedematous pancreatitis. The pancreas may be normal in this situation. The enhancement is often normal. It can be slightly heterogeneous enhancement due to edema. You can see in this case, slightly bulky pancreas, a bit of edema in between the parenchyma, and there may be peripancreatic haziness, slight haziness in the fat there, a bit of stranding, and you may see some fluid as well. With necrotizing pancreatitis, we get non-enhancement of the pancreas, and this is central necrosis. You can see the head of pancreas enhanced quite well, non-enhancement of the neck and body, and then some non-enhancement extending into the tail of pancreas. It's useful to try to quantify the extent of the necrosis that we see. Sometimes the pancreas may just show heterogeneous enhancement, or there's less than 30% non-enhancement, and in that situation it's difficult to say whether there's patchy necrosis or edema causing this change, and then it's worth considering repeating the CT a little bit later to see if the necrosis is demarcated. But if the patient is well, the CT can be repeated further down the line. And this example of CT in day 4, we've got change of pancreatitis, a bit of edema around the head of pancreas, a bit of non-enhancement, some linear non-enhancement in the head uncinate process, and at day 17 you can see quite extensive demarcated necrosis in the head of pancreas and also in the surrounding fat. Peripancreatic necrosis is due to fat necrosis as a result of lipase being released from the inflamed pancreas. What we see on CT is soft tissue thickening and stranding in the fat, extending down the paracolonic gutters or the base of the small bowel mesentery. Differentiating fat necrosis from simple fluid or edema can be difficult. MR or ultrasound can help, but that's probably not clinically indicated. You probably want to change management. But there should be an assumption towards the presence of fat necrosis if there's any doubt. And here we see changes around the pancreas. It's not typically fluid density here, it's almost soft tissue density, and this is what fat necrosis looks like. And here's another example of solid looking inflammation anterior to the head of pancreas. Central gland necrosis is not separately classified in the revised system, but is an important finding to point out to the clinician. It indicates full depth necrosis of the pancreatic neck and body with separation of the head and tail, and this because there's a collateral blood supply to the head and tail that maintains their viability. Often the main pancreatic duct is disrupted in the midline, and the sequelae of this could be persistent secretion from the tail, resulting in a persistent collection or fistula of the pancreatic duct. And that may require a distal pancreatectomy if there's a persistent fistula. So in terms of evolution, usually in the first week of pancreatic necrosis, the necrotic tissue is quite solid. Over the first few weeks, it tends to change to semi-solid consistency, and then weeks to months later, it can liquefy. But the necrotic change often absorbs, whether it's liquid or solid, or sometimes it can persist for many months or sometimes years. Infected necrosis is a major risk factor for multi-organ failure, and this occurs in 20 to 30% of patients with an associated increase in mortality. In detecting pancreatic necrosis, it can be quite difficult. If there's gas within a necrotic collection, that is very suggestive in the right clinical context. Obviously, the presence of gas may indicate a fistulation into adjacent gut. Sometimes you may see quite a thick and enhancing wall with of collection with stranding in the fat. And again, if the patient's septic, that would strongly indicate infected necrosis. And this is a more typical example of infected necrosis with lots of pockets of air within it. The infected necrosis may require surgical debridement, but there is a shift towards conservative management. So, looking at the terminology, with the new system of classification, when you look at CT, the main descriptions needed is to decide whether there's any solid material within the collection, solid material indicating necrosis, either fat necrosis or pancreatic necrosis. Is the collection walled off or not, and is it infected or sterile? So the descriptive term that have been promoted, suggested, is that time interval is an important criteria for classification. If you see a fluid collection within 4 weeks after acute pancreatitis and the collection is of fluid density without any solid material, then we describe this as an acute peripancreatic fluid collection. If there's any solid material or necrosis within the collection, it's described as an acute necrotic collection. And these collections evolve usually after 4 weeks to walled-off collections. So if it's a walled-off simple fluid collection without any solid material, it's called a pancreatic pseudocyst. It's usually thin-walled without any solid content. If there's any solid necrosis, the acute necrotic collection is defined as walled-off necrosis after 4 weeks. And any of these collections may be sterile or infected. So I'll just show you some examples. Acute peripancreatic fluid collections are quite common in acute pancreatitis. They should really be of homogeneously low density without any well-defined wall and no solid elements. And this is some examples of fluid tracking down the left flank in this patient with acute pancreatitis, and some more fluid here on the right flank. Acute necrotic collections are fluid and necrotic tissue. They often result from liquefaction of necrotic tissue, usually over several weeks. And on CT, the density is usually heterogeneous rather than homogeneous. And here we can see an acute necrotic collection hasn't got a very clear wall at this stage. And similarly here, but with higher density necrotic collection, you can see necrosis in the pancreas here, head of pancreas, and here's the necrosis in the tail of pancreas. So the presence of that necrosis means these collections are not going to be simple peripancreatic fluid collections. Again, in the first week, differentiating the two can be difficult depending on their density, and the MR and ultrasound can help if thought to be clinically necessary. So pseudocyst is a very misused term. A lot of people are used to describing any pancreatic collection as pseudocyst, which is clearly wrong. Pseudocysts are the evolution of the simple fluid collection, the acute peripancreatic fluid collection, after 4 weeks when it gets walled off. And the wall is a well-defined wall of fibrous or granulation tissue without any solid elements, as it should be of homogeneous density. Half of these pseudocysts resolve spontaneously, and some can go on to cause pain and infection, although infection is rare. Here's some examples of pseudocysts up against the posterior wall of the stomach, thin-walled, homogeneously low density on CT. Walled-off necrosis is the evolution of post-necrotic collections, this is an example I showed you earlier, post-necrotic collection, and then later on it evolves to becoming a walled-off necrotic collection. You've clearly got pancreatic necrosis there. Heterogeneous CT density can be infected, and then we call that infected necrosis. Can be entirely solid, and usually resolves slowly, but may never resolve. So, just to summarize, we have to describe collections as liquid or solid. Are they walled off or not? Less than 4 weeks, the two terms that should be used are acute peripancreatic fluid collection or acute necrotic collection, and then after 4 weeks, pseudocyst or walled-off necrosis. Just briefly mention some of the other complications we can get. Splenic vein thrombosis is quite common. Often the splenic vein becomes occluded. It's less common to see portal vein or SMV thrombosis. Pseudoaneurysms can occur, and if there's suspicion of bleeding, then an arterial phase should be performed as well as a venous phase. There's obviously a risk of rupture, and these pseudoaneurysms should be embolized. In terms of other imaging modalities, ultrasound is also useful for detecting gallstones that may not be seen on CT. And ultrasound is also quite useful in deciding whether a collection is, how much collection that you're assessing on CT is solid or liquid, in helping to plan whether to insert a drain or not. MRI can also differentiate solid from liquid tissue within a collection. You can look for bile duct stones. And it's quite useful for interval scans after severe pancreatitis if we're just assessing the amount of collection remaining, since that will reduce the CT radiation impact. And obviously in patients that have renal impairment or CT contrast allergy, MR can be useful. And this is just a couple of examples. A large pancreatic collection on CT. You can see already there's areas of altered density within it, so there are going to be some solid elements that we can infer on CT, although generally it's quite low density. And this is a collection on CT which is slightly high density, it's a border necrosis, and on MR you can see the necrotic material within that, a bit of oedematous fluid material as well. So just briefly going on to the drainage of collections. Draining pancreatic collections can be quite a significant undertaking. Patients can get quite sick, they can be very sick before drainage, or they can get quite sick after a drainage. And it can take many weeks or months of drain care, drain changes and upsizing the drain, and just putting the drain in can introduce infection into a sterile collection. So ideally it should be in some specialist centre with ICU facilities. A patient may end up in ITU. There should be advice of a pancreatic surgeon, and obviously experienced radiologists and endoscopists may be needed as well. This is just an example of pancreatic collection before drainage. It's a walled off necrosis, and after drainage it reduced significantly in size, but lots of pockets of air, and the patient became more septic, so we converted that into infected necrosis. The indications for draining is if you think the collection is infected, or if it's enlarging, or the patient symptomatic from mass effect. And the symptom may be pain, nausea, vomiting, or just general unwellness. It's best to avoid draining collections early on in acute pancreatitis, and the main questions when you're considering drainage is the collection infected, and how much solid material is there in that collection as opposed to liquid material. This is a patient following acute pancreatitis on day 5. There was slightly ill-defined but not properly walled off fluid collection superiorly, and by day 15 becoming more walled off, and day 23 it's expanding. The patient had a lot of nausea, and then this collection was drained. Is FNA necessary? It's strongly advocated in the literature to assess whether there's infected necrosis present in a pancreatic collection or in pancreatic necrosis, but it can be falsely negative in 25% of cases, and it can also introduce infection into a sterile collection. I mean, in our experience, my experience, it's best to just insert a drain. I don't think I've ever been asked to perform FNA to check for infection. If you're worried about a collection, put a drain in, even if we think it's necrosis. So percutaneous drainage can be performed by a direct route. It can be performed transgastric through the anterior and posterior walls of the stomach into the back of the collection. That reduces the risk of fistula forming to the skin, and it can be internalized endoscopically. The endoscopist will go down, cut the drain in the stomach, and leave it lying within the stomach. The retroperitoneal approach is preferred for necrotic collections through the left flank, and then this can be upsized to larger drains, and if the collection doesn't improve, laparoscopic necrosectomy can be performed through the same route. And this is just showing some examples of transgastric drainage. It can be done under CT. We've got a needle passing through the anterior posterior wall of the stomach into the collection at the back of the posterior of the stomach. And this is following drainage. The collection is reduced significantly a few weeks later. And if you don't use CT, you can use a combination of ultrasound and fluoroscopic guidance to puncture the collection through the stomach. Retroperitoneal drainage. You have a large collection extending to the left flank. You can pass a drain through the flank with relative safety, the interior to the spleen, and then the drains can be changed regularly under fluoroscopic guidance. And the drain change itself helps in reducing the size of the collections over many weeks, sometimes months. And eventually this is infected necrosis, and eventually they resolve completely. So traditionally, surgical repairment was the way to deal with infected necrosis, but this is a high morbidity and significant mortality. There's several papers that have now described radiological treatment of infected necrosis over the last 10-15 years, and the critical elements are regular drain changes, upsizing the drain, and good drain care, and usually it's long-term, weeks or months of drainage. And they've said 50% in this paper, but freely 50% patient cured by drainage alone. But it depends on how long you wait before you proceed to necrosectomy. But certainly in our experience, very few patients go on to necrosectomy. Just an example of draining infected necrosis. Again, this is a patient with septic, not a big collection, but approach through the left flank, and then eventually 6 weeks later, with a few drain changes in between, the infected necrosis is essentially resolved. So percutaneous drainage of infected necrosis can be very effective, ideally by the retroperitoneal approach to the flank. Initially, a small drain is reasonable, and then that can be upsized under fluoroscopic guidance. And solid components can be provided very slowly, and regular drain change is required, and also upsizing. This is a patient who had percutaneous drainage, drain fell out, the necrosis got more infected, we drained it again, and then we upsized for laparoscopic drainage. And then the surgeon inserted a large drain following a laparoscopic debridement through the same tract, and eventually that infected necrosis resolved. So in conclusion, the new classification system for acute pancreatitis defines pancreatitis as either interstitial oedematous pancreatitis or necrotic pancreatitis. There's a simplified way of describing the collections following pancreatitis. The acute collection in the first four weeks should be described as acute peripancreatic fluid collections or acute necrotic collections. After 4 weeks, they should be described as pseudocyst or walled-off necrosis. And drainage of collections is increasing, and also of infected necrosis, which can be treated with percutaneous drains.